For the next 45 minutes or so, we're going to talk about disruptive behavior disorders. I have no financial disclosures. Our objectives will be to learn how to appropriately diagnose disruptive behavior disorders, which include disruptive mood dysregulation disorder, oppositional defiant disorder, and conduct disorder. We'll identify comorbidities to disruptive behavior disorders and be able to effectively treat both disorders simultaneously. And then we'll discuss different treatment modalities and know when to implement different treatment modalities. So a little outline of how we're going to do this today. We're going to review the criteria for the different disorders. We're going to talk a little bit about ADHD because it is highly comorbid with disruptive behavior disorders. We'll discuss some risk factors. We'll talk a little bit about how to interview the child, and then we'll go into treatment and prevention. So I'm sure everybody has kids with oppositional defiant disorder, patients with oppositional defiant disorder. Have any of y'all seen kids who've been diagnosed with disruptive mood dysregulation disorder, DMDD? Have y'all heard of that? Yeah. And so, by definition, disruptive behavior disorders are the ODD and the conduct disorder. Disruptive mood dysregulation disorder is a newer diagnosis that was published in our new DSM-5 Diagnostic and Statistical Manual in 2013. It is actually classified as a mood disorder, but I thought it's very important to today's discussion, so we will be talking about it as well. So we'll go through the criteria for each disorder briefly. Oppositional defiant disorder is a pattern of angry and irritable mood, argumentative or defiant behavior, or vindictiveness lasting at least 6 months with at least 4 of the below symptoms: losing temper, easily annoyed, angry and resentful, argues with adults, actively defies others or refuses to comply with requests, deliberately annoys others, blames others for his or her mistakes or misbehaviors, and has been spiteful or vindictive at least twice within the past 6 months. And to be diagnosed with oppositional defiant disorder, it can't be just towards a sibling, because that is a very special, the sibling relationship is a very special relationship. And so it can't just be your brother or sister that brings this out in you. It has to be, in more than one environment, or at least one other environment. This disturbance is associated with distress in the individual or in others, family, peer group, school, or it has a negative impact on school, educational, occupational, or other areas of functioning. So the symptoms are part of a pattern of problematic interactions with others. These kids don't consider themselves to be a part of the problem. They don't, they say, I'm not angry, I'm not defiant, it's everybody else. They make me this way. They justify their behaviors in response to others' unreasonable demands. Symptoms actually often begin in preschool or early years and can persist all the way into adulthood as irritability, stubbornness, passive-aggressive personality. Prevalence is 3 to 6% at any time, a little more common in male, 1.6 to 1. Lifetime prevalence of ODD is about 10%. So conduct disorder. Conduct disorder is a repetitive, persistent pattern of behavior in which the basic rights of others are violated or societal rules or norms are violated, with 3 or more of the following in the past 12 months. And we see there are about 15 different criteria. And the first group of criteria is aggression, bullying, threatening, intimidating others, initiating fights, using weapons, not just a knife or a gun, but a rock, a brick, a bat, physically cruel to animals, physically cruel to people, stolen while confronting a victim, and forcing someone into sexual activity. So of course, these are our most serious criteria of conduct disorder. Some of the other criteria: deliberately engage in fire setting with the intention of causing damage. A lot of kids, unfortunately we see play with fire, but kids with conduct disorder, they intended to cause some damage, deliberately destroyed others' property, has broken into a home or car, often lies to obtain goods or favors or to avoid obligation, has stolen without confronting a victim, And then, finally, some of the criteria: staying out late at night, running away from home overnight, or school truancy. And of course, these bottom three, we see teenagers, do these kind of things, maybe some peer pressure, they sneak out of the house, they skip school, maybe they're peer pressuring into maybe some property damage. And so there is a wide range of what conduct disorder can be. Similar prevalence to ODD, about 3 to 5%, lifetime prevalence 10%. And it is defined as either childhood onset or adolescent onset, childhood onset being less than age 10. Those with childhood onset are at greater risk to have, more severe problems. And if you look at a lot of these, a kid less than 10, violence, property damage, setting fires, theft. That's very serious. Most of the kids with childhood onset conduct disorder are male, are very physically aggressive, and have a prior diagnosis of oppositional defiant disorder. And most of them also have ADHD. Childhood onset conduct disorder children are 3 times as more likely to be convicted of a violent offense when they get older, and are more likely to have significant educational, social, and occupational problems. And this is compared to adolescent onset conduct disorder. There's something called callous unemotional traits in certain kids with conduct disorder, also called limited prosocial emotions. And so these are kids who, they do the things they do, don't really have any guilt or remorse. They don't have empathy for others. They're unconcerned. They have just a very shallow affect. In childhood onset, almost a third of those kids have callous unemotional traits. They are more aggressive and more severely impaired. And these are the kids who instigate the crimes rather than the ones who get kind of sucked into it. And they have more of a premeditated aggression. They'll fight somebody, just because. And understandably, these kids are more difficult to treat. They don't respond as well to punishment. They don't care. They're not as affected. They often underestimate the likelihood of being caught or punished, so they are more risk takers. And those with the callous unemotional traits, there is a higher genetic influence to their conduct disorder. And disruptive mood dysregulation disorder. So that is a newer diagnosis that came out in 2013 in our DSM-5. Really, I think it was set out to a diagnosis to capture these kids who are significantly more than oppositional defiant disorder, but they didn't really meet any other. They didn't meet criteria for depression. They really didn't meet criteria for bipolar. But they were looking for a mood disorder that would encompass some of these symptoms. So DMDD criteria. Severe recurrent temper outbursts manifested either verbally, verbal rages, and or behaviorally, physical aggression towards people or property that's grossly out of proportion in intensity or duration to the situation. Temper outbursts are inconsistent with developmental level, and they occur on average at least 3 or more times a week. Mood between the outbursts is persistently irritable and angry most of the day, every day, and is observable by others. So these are kids who are just always moody, always in a bad mood, and always, kind of ready to start something. These criteria have been present for 12 or more months, with no more than 3 consecutive months without all of the symptoms, and have to occur in more than one setting. And so DMDD did come about to reduce misdiagnosis of bipolar disorder. We see, these kids, they do have very labile mood, very unstable mood, but they didn't have the episodicity of manic episodes. They didn't have the criteria for decreased need for sleep, increased energy and things like that. The prevalence, kind of comes from retrospective studies, as it is a newer diagnosis. Prevalence anywhere from 1 to 3%. And there's a high comorbidity with depressive and anxiety disorders. And by definition, the diagnosis, DSM likes to exclude, certain diagnoses that can't co-occur So that diagnosis of DMDD cannot coexist with oppositional defiant disorder, intermittent explosive disorder, or bipolar disorder. It can coexist with major depressive disorder, ADHD, conduct disorder, substance use disorders, and other disorders. So by definition, if a child meets criteria for both disruptive mood dysregulation disorder and oppositional defiant disorder, DMDD diagnosis is given because it's really seen to be the more extreme of the two. If a child has any history of manic or hypomanic episode, then by definition, they cannot be diagnosed with disruptive mood dysregulation disorder. And so maybe they would be, of course, bipolar and maybe oppositional defiant. Now, the comorbidity between the three. So about a third of kids with oppositional defiant disorder will go on to develop conduct disorder. But the majority of those with conduct disorder, never had oppositional defiant disorder. And then by just looking at the criteria, kids diagnosed with disruptive mood dysregulation disorder, 90% of them also have those criteria for oppositional defiant disorder. In addition, there's a very high rate of ADHD with all three of these diagnoses. Having ADHD in addition will cause greater impairment and will be more difficult to treat. And so 50% of kids with ADHD also have a disruptive behavior disorder. Youth who have both ADHD and disruptive behavior disorder are typically going to have more severe symptoms of both and greater impairment in functioning. And they're more likely to have psychiatric disorders later on. These youth are at higher risk for academic disengagement and peer rejection. Girls are more likely to go have undiagnosed and untreated ADHD, which actually can increase their risk of developing oppositional defiant or conduct disorder. And if we think about the kids with ADHD, and I feel bad for them sometimes. Like they're always getting in trouble. They're always getting picked on. If there's a problem in the classroom, the teacher kind of goes to them first. Sometimes it is they did start it, but there's times also they feel like they're very unfairly treated. When you think about kids with ADHD, well, they have problems paying attention. They're not listening as well. They're not following the instructions. But then the teacher may think, well, he's being very defiant. He refuses to comply with my requests. He's not listening. He's got ODD. Kids with ADHD, the hyperactive type, they talk, they fidget, they move, they interrupt others, blurt out answers. And then, you think the adult might say, well, they're deliberately annoying the other kids in the class. They won't let the other kids speak. They're very disrespectful. Kids with ADHD have poor attention, poor focus. They may incorrectly complete the task. Well, then here the teacher, and then the kid says, well, the teacher didn't tell me. Well, is that his ADHD, or is he being defiant and blaming others? And so you see, there's really a high overlap between some of the criteria and how you interpret them. And I think the key is to determine if these behaviors are intentional or not. I think a lot of kids with ADHD, these problems happen naturally, and then their response, they tend to develop oppositional defiant disorder just because. That interaction with the teacher and with others around them. Now, what are some risk factors for disruptive behavior disorders? So now prenatally, we know that high maternal stress or depression not only affects, increases cortisol and affects the HPA axis, but also if mom is stressed or depressed, she's going to be less attentive to the infant. Malnutrition can be a risk factor. Low folic acid is associated with decreased head circumference and hyperactivity. Our typical Western diet, high in processed foods and sugars, is associated with more externalizing behaviors in kids. Preterm birth, we know that preterm birth increases the ADHD risk 2 to 4 times. There's actually some conflicting studies on increased rates of oppositional defiant disorder and conduct disorder. Lead exposure, perinatally, we know has an increased risk of externalizing behaviors. Alcohol, fetal alcohol syndrome, can cause ADHD, impulsivity, low IQ, learning disabilities. Maternal smoking, we know, increases the rates of ADHD, and it actually increases the risk of conduct disorder fourfold. Multiple genetic risk factors for disruptive behavior disorders. You see dopamine receptors, serotonin transporters. All three of the diagnoses can have some genetic component. Poverty. Poverty is actually the number one risk factor for these disruptive behavior disorders. The rates of disruptive, aggressive, and delinquent behavior is as high as 40% among the economically disadvantaged populations. So almost half the kids, in poverty will have disruptive behavior disorders. Of course, you think about, the stress of being in poverty. The majority of single parents live in poverty. What causes them to get in poverty? Most likely they have a lower educational level, they have lower income jobs, therefore they may be working longer hours. They're not as at home as much to monitor and supervise their kids. More likely to be of younger age. They're stressed, they're depressed, they're not as warm to their kids. The interactions at home are going to be less frequent because they're busy working, and also just not as positive. Poverty is also associated with a poor diet, smoking, living in a high crime neighborhood, and a higher rate of divorces and breakups. And so poverty, causes a lot of chaos in the family. And actually, getting out of poverty, does change outcomes. Welfare recipients, people who weren't on welfare who do get welfare, they have a reduction in externalizing behaviors. Indians, people on Indian reservations, there can be a lot of crime there amongst the teenagers, but there have been some data that some of these Indian reservations opening casinos, having more cash flow in, actually leads to a lasting reduction in antisocial behaviors. Abuse, of course, is a significant risk factor for developing a disruptive behavior disorder. The most frequent outcome of being abused is to be aggressive. Almost a fourth of kids with conduct disorder have been physically abused, and they may be more likely to engage in violent or aggressive behaviors. Those who've been sexually abused have a 12 times higher risk of developing conduct disorder. And abuse is not just physical, sexual, but also emotional abuse, neglect, rejection. These things can take a big toll on a child. Family structure. Single parents is definitely a risk factor, not only because it can be more associated with poverty, but because the single parent is busier. Most likely they're working, they're not at home as much, the child has less supervision, the parent is less of a role model because they're not as available. As far as family structure, when a divorce happens, it is fairly common for kids, 20% of kids will develop conduct issues. Typically these are short-lived, just adjusting to the separation. In some chaotic families, high conflict, domestic violence situations, a child's behavior may improve after the separation. Of course, these tend to be the couples that get back together again and again. And there's actually been data, multiple maternal relationship transitions. Mom gets a boyfriend, moves in with him, they break up a month later, and the cycle perpetuates. This kind of chaos, is not good for the kids and could lead to more antisocial behaviors. School, kids spend, about a third of their waking hours in school. School does have a direct influence on a child's behavior, both not only the kids, but also the teacher relationships. You want that teacher relationship to be a positive one. A good teacher should be constructive and consistent with punishment, but not overly severe. A school's acceptance of negative or aggressive behavior is highly influential on the occurrence of disruptive behavior disorders. If this is a school that's constantly having fights and the school doesn't really make a big deal out of it, the fights are just going to perpetuate and get worse. Frequent changing of schools, that usually indicates maybe some financial issues, residential instability. And so interestingly, the more school moves a child has, the more likely they will be to be arrested as an adult. Depression in a parent. Maternal depression is prevalent in 17 to 24% of mothers of young children, obviously to varying degrees of severity. Severe depression can be highly correlated with behavioral problems in children. And maternal depression is also correlated with a difficult infant temperament. And so we think that the temperament, I think a big part of infant temperament, they are born, with their temperament, but in those early months, the caregiver influence can certainly lead to the infant having a more difficult temperament. Major depressive disorder in either parent will increase the risk of conduct disorder by 5 times. The kids will have a worse outcome if their mom has depression. Okay. Also, we have parents with oppositional defiant disorder and disruptive mood dysregulation disorder, parents with substance use disorders, and not just active, but also in recovery, because they still tend to have the same personality issues and difficulty dealing with stress. So parents in recovery can contribute to the child's behavior disorders. Also, parents having antisocial or borderline personality disorder. Parenting practices. Parents with depression are less likely to respond positively. They don't respond to the good behaviors. They only focus and notice the negative behaviors. Parents with personality disorders or substance use disorders, may be very harsh and inconsistent with their discipline. They're less sensitive or nurturing. They also don't do much positive parenting and don't really bond. They're more disengaged from their children. Lack of warmth and praise increases some of these negative behaviors in preschool and school-age children. Lack of rules or being overly permissive can increase youth rates of antisocial behaviors. And then lack of monitoring in adolescence can lead to increase in antisocial behaviors as well. So what are some of the treatments of disruptive behavior disorders? First, we have to think about how to engage and interview the child. I know sometimes, in clinic, the family comes in, and sometimes the mom or dad, they just start in talking about everything. He does this, he doesn't care about this, just constant, what he's doing wrong. There are times when I feel like they're really berating the child. There's times that I may ask the parent to step out, try to talk to the kid without being interrupted, to talk about the negative things that parents bring up. I think it's important, we want the kid to tell us their side, what the mom says, well, he got in a fight with Tommy. Well, what happened? What did Tommy do? How did this start? I try to be non-judgmental with the kids, instead of like, why did you get in a fight? Well, why did this person make you mad? How did it start? Kids, I find it takes kids a minute to answer sometimes. You ask them a question and, you kind of see them formulating their answer. It might take them a few seconds to start talking. I do notice the parents at times, they just jump right in. See, he won't tell us. And I'm like, I think he was about to. Definitely give the kid time to talk. Let them tell their side. Try to be non-judgmental. And then we also, want to talk with the parents about anything they may be doing to contribute to these issues. What are the parents' expectations? What are typical parenting practices or punishments? How do you handle some of these behaviors? And are parents consistent in their consequences? And does the kid have behavior problems just at home or in other settings as well? When a parent comes in and says, well, he's perfect at school, he's perfect at grandmother's house, he, no other problems just at our house, well, then you have to think, what's going on at home that's causing or contributing to some of these behaviors. So we'll talk a little bit about therapy for behavior disorders. Therapy, disruptive behavior, oppositional defiant conduct disorder. Really, therapy is going to be the mainstay of treatment. Effective treatment, we really have to engage with the parents and the caregivers. I feel like often the parents, they just want to send their 6-year-old kid back to the therapist and have the therapist fix them, and it doesn't really work that way. The parents have to be very actively engaged and involved in treating of their child. Some things to ask parents is, where do you think this comes from? I mean, do you think that these things are in your child's control or out of your child's control? Sometimes they say, well, it's his ADHD. There's nothing we can do. We want to explain to the parents, what the nature of therapy is going to be like. What's the parent's role versus the child's role? What are some expectations of treatment? And we want to set some realistic goals. So ideally, the most evidence-based treatment is called parent management training or behavior parent training. It can be a challenge to find someone, and this is kind of like a manualized therapy, specific way of therapy. So it can be difficult to find somebody who specifically does parent management training or behavior parent training, but there are many therapists out there who do work with the family, work with young kids and their families. And so really, the point of therapy in kids with these behavior disorders is to help the parents parent, to help them learn to communicate better with their kids or more effectively with their kids, to listen to their kids, and to really be able to have appropriate consequences, rewards for the positive behaviors, consequences for the negative behaviors. And really the parenting practices are what's going to modify the child's behavior. In a therapy session, the therapist or clinician will model and teach the parenting strategies for the caregivers to implement, with the aim of increasing the positive behaviors and decreasing the negative behaviors. And generally, in an ideal world, this would be like maybe 2 to 3 months, 10 to 12 sessions. And the child doesn't even necessarily need to be present for some of these sessions, because really it is working with the parent on how to engage with your child. And the parent needs to not just attend, but participate, engage, be willing to do homework, things like that. Now we think, so what are some of the barriers to parent management training? Of course, finding a therapist is a number one. Those in poverty, who are at the highest risk for disruptive behavior disorders, they may have multiple barriers. They have no transportation. They don't have a babysitter. They're too busy working. They can't get there in time. Parents may be so stressed that it's hard to get motivated. They feel overwhelmed and helpless. I can't do this. He'll never get better. Of course, some of these agencies have extensive waiting lists. And then you think about the parental perception of treatment. They think, the therapists, they're going to blame me for everything. It's not going to go well. So these are some reasons for no-show. For no-show rates to initial appointments, can be 50% or more, and many families only remain in treatment for a few sessions. And so what does help? Of course, weekend hours, evenings, childcare provided, transportation, group sessions to allow for social support. It can be difficult to find a therapist who is willing to work with young children and families, but they are out there. And then there are self-help books that can be useful, either while waiting to get into therapy or if they're not going to go to therapy in the first place. And I've listed some books. The Caston Method for Parenting the Defiant Child. Dr. Caston is a psychologist at the Yale Children's Center. And he's done some really good stuff. He has a book for parents and also a book for clinicians or providers. And I think there's also a video that comes with the book, like a 15-minute video. And sometimes that's more accessible for the family because they might not want to sit and read a book. And then other books, I'm sure y'all recommend books at times, 1, 2, 3 Magic, the explosive child, your defiant child. And there's, of course, hundreds of books out there. We'll talk a little bit about medication for disruptive behavior disorders. Now, the FDA has not approved any medications for oppositional defiant disorder, conduct disorder, or disruptive mood dysregulation disorder. But medication can be used to target the behaviors that cause significant impairment and stabilize impulsivity and mood, which can lead to high-risk behaviors. Majority of the studies on ODD and conduct disorder, majority of those studies do include kids with ADHD. ACAP practice parameters, that's the American Academy of Child and Adolescent Psychiatry, state that medication should be reserved as used as an adjunctive treatment when they're already receiving some comprehensive psychosocial treatments. The greatest evidence to support psychopharmacologic intervention is stimulant treatment in youth with ADHD. The Texas Children's Medication Algorithm Project, their recommendation also is concurrent medicine with therapy. In England, their care excellence guidelines, psychosocial interventions are first and essential. And then for those with severe anger and emotional dysregulation who fail to respond to psychosocial treatment, they actually recommend risperidone. But we see, all of these recommendations, it's really therapy, number one. Now, as far as medication, stimulants are recommended as the first-line treatment in those with comorbid ADHD and aggression. There are over 40 randomized controlled trials on effects of stimulants on symptoms of aggression, oppositional behavior, and conduct issues. And then actually, even if a child doesn't have a formal diagnosis of ADHD, stimulants can still be used and can be very effective in treatment of aggression. A big part of ADHD is impulsivity. And kids with disruptive behavior disorders, they have a high degree of impulsivity. And so they may not meet, check off 6 boxes to be diagnosed with ADHD, but they still do have some criteria. In landmark study, multimodal treatment of ADHD study, treatment of methylphenidate plus or minus behavioral treatment showed the greatest improvement in those with ADHD and oppositional defiant or conduct disorder. Now, the methylphenidates versus amphetamines, I know there's the question often of which medicine do we start with. Personally, I tend to be the methylphenidate class. I feel like the amphetamines can be a little harsher on the GI system, a little more side effects, a little more irritability and moodiness. So just any kid, generally my first line will be like a Ritalin type, like maybe, methylphenidate. But that's not, amphetamines are just fine too. But so, we pick one of the medicines. Start it on a child with ADHD, and about 2/3, 65 to 75% will respond to the first stimulant. The other 30% will have either no response or they'll have some pretty bad side effects. The next step typically is to try the other class. If we tried the methylphenidate, well, now let's try an amphetamine. And then about 15% of those will respond. And so we have an overall response rate after trying both stimulants of about 85%. Have y'all seen ever stimulants worsen mood, worsen aggression, violence? Yeah. I feel like working in the hospital, I see it all the time. But it's really, statistically, it's not quite so common. But we definitely, they try that first dose, 5 milligram, methylphenidate or amphetamine, and, they're just out of control. So that does happen on occasion. And so, in that case, if we try one medicine, they have a pretty bad reaction, we may not want to try the other class. We may want to maybe skip and try something else. Antipsychotics, I'm not saying this is our next step, maybe, but so there have been a couple of other big studies. Treatment of severe child aggression study, 169 youth with ADHD plus either oppositional, defiant, or conduct disorder. So the first few weeks, the kids all received stimulant treatment and some parent training for 3 weeks. If the aggressive behavior was still present, they were randomized to either risperidone or placebo in addition to the stimulant. And the risperidone was found to be superior in improvement of aggression. Also, the treatment of maladaptive aggression in youth project showed, first you treat the underlying psychiatric disorder. If they don't respond to psychosocial intervention or first-line medication, then an antipsychotic trial should be considered. If they fail one antipsychotic, you can try another. You can also try a mood stabilizer, Depakote, or lithium. As far as the antipsychotics, risperidone is the most extensively studied medication in the treatment of aggression in youth. Both short and long-term studies show significant reduction in aggressive symptoms. Aripiprazole has also been shown to reduce aggression in youth. Both of these medicines are FDA approved for aggression in autism. So we do know that there is, these medicines are used in kids down to age 5 and 6, age 5 for aripiprazole, age 6 for, or I got that reverse, age 5 for Risperdal, age 6 for Abilify. And so we know in kids with autism, the medicines can be used that young. And so sometimes in kids with severe behavioral issues, we will probably go to Risperdal or Abilify. Other antipsychotics, the quetiapine, olanzapine, clozapine have positive data, but the effects are not as robust. The effect size for risperidone is actually 0.9, same as with the stimulants. We also have alpha agonists. Clonidine and guanfacine are very good medicines. I use them a lot. I use 10X all the time. They both have positive studies showing improvement in conduct and aggression. They can be combined with stimulants or they can be used alone. They can reduce some of the negative side effects of stimulants. Now, atomoxetine, which is a norepinephrine reuptake inhibitor, some randomized controlled trials show that they can reduce ODD symptoms in those who also have ADHD, but higher dosing is required. But then a meta-analysis of these trials showed that really overall there's not a reduction in aggression. Now, if someone's already on atomoxetine and it's helping, by all means, continue it. And then some of the mood stabilizers can also, there have been studies on those too, as far as helping with disruptive behavior disorders and aggression. Valproic acid, carbamazepine, oxcarbazepine, lithium. These tend to have a little bit lower effect size, but they certainly can be effective. But then we know that these mood stabilizers do require frequent monitoring and blood draws, which kind of turns kids and families away. So as far as take-home points about medication, it's probably best to start with a stimulant, even if they don't meet those full criteria for ADHD. They really can help with the impulsivity. Risperdal, I'm not saying for y'all to just go start Risperdal on everybody, but some of the kids I see, their defiance, their behavioral issues include like maybe trying to drown a baby or stab the teacher. And so, when these kids get back from the hospital, maybe you'll understand, maybe why they ended up on an antipsychotic. They need something maybe a little bit more potent. Alpha agonists. Probably in outpatient, I'll probably consider, a stimulant first, alpha agonist probably second, and then move on to maybe an antipsychotic. And then, of course, other mood stabilizers can help as well. Clinical course of disruptive behavior disorders. Into adulthood, those with oppositional defiant disorder are at increased risk for antisocial behaviors, impulse control problems, substance abuse, anxiety, and depression, so kind of everything. 40% of adolescents with conduct disorder do go on to develop antisocial personality disorder. And these people are going to have increased rates of crime, substance abuse, and other psychiatric disorders in general. Prevention of disruptive behavior disorders. Really the earlier the better. If you're seeing young kids, toddlers, well child checkups, You know, I mean, we really want to know how the kid is doing, how did he and the caregiver, child and caregiver interact, and what some of the problems are. Because really we have to start young to try to help these kids, help them do better. We want to identify, what we can do to help the parents, again, referring parents to counseling themselves. I can tell you're overwhelmed. Have you talked to anybody? Maybe we can kind of just open that door for the parent to get some help and manage their stress level. Some counseling agencies offer in-home visits, group parent training. The Head Start program, we have, kids going into the Head Start program, I think at age 3, that has been shown to reduce adolescent rates of delinquency and antisocial behaviors. So definitely something you can encourage your at-risk families to get their children into. Also school-based programs. Some schools do have, I know all schools have counselors, but some schools have actual therapist counselors who are not employed by the school board, but who are allowed to go in and help and work with the kids and the families. Sports and other activities, extracurricular activities, can be obviously great for the child, help foster confidence and participate in pro-social activities, have some more positive adult role models. So I think that's it.